is Susan Garcia, and this is
Nafisa Warwick.
And we will be introducing the Judet method in the anterior posterior oblique projection,
In the right posterior oblique and left posterior oblique positions. Hello, ma'am. My name is Nafisa. I'm going to get an x-ray on you today. Can I have your first and last name?
Yes, Susan Garcia,
And your birthday?
March 1st, 1992.
And Miss Garcia. All right. So is there any chance of pregnancy today?
No.
No? Well, it's going to... Okay, ma'am. On a scale of 1 to 10, how bad is your pain?
Maybe like a 9.
9. And how long ago was this accident?
About an hour ago.
About an hour ago. All right. So we're going to get an x-ray of the acetabulum.
Okay.
All right. Let's go. Okay. And what side is your pain on?
Right here.
All right. Do you have any jewelry on underneath?
No.
No?
I think they took everything off.
Okay. Let's just double check you for any lines.
Okay. I have an IV right here, but that's it.
That's fine. We'll just be careful of that, okay? Hello, Dr. Barnes. The patient is connected to an IV. Is it okay that we discontinue the fluids? Okay. Thank you. Okay, Miss Garcia, we're going to disconnect your IV for a little bit while we do the imaging, okay? All right. Okay. Oh. Yay. So you want to make sure you detent your tube to your table bucky. And you will know that once the green indicator lights are on. All right, and then you have your 10 by 12 imaging plate in the bucky. It is lengthwise. You make sure that the tube and the IR are aligned, and they're centered. And you close that up. You make sure you have your 40 SID to the table bucky for your imaging. And make sure your image receptor is on properly because it will not work. Everything is green, so that means we are a go. I have my light source field open, and we're going to position the patient. Okay, Ms. Garcia, we're going to get the internal rotation. So I'm going to ask you to roll over to your left side, and I'm going to place this sponge underneath you. Wonderful, you're doing good. And go ahead and relax down on that. All right. So now we're going to feel for the aces, which is there. And then we're going to go 2 inches below, which is my 2 fingers, which is there. And now we're going to move the table to get the patient centered. Right. Make sure we open the collimation. And we're going to now measure for our technique. I'm going to measure from the table, the IR is, to the crosshair. And Mrs. Garcia is a 23. And now we'll go over. We're going to do it at 85 kVp and 16 mass. So, Ms. Garcia, don't breathe, don't move. Okay, so next we're going to do the external rotation. So, Ms. Garcia, I'm going to ask you to roll over, and I'm going to remove the wedge. And then carefully go around on the other side. All right. So I'm going to ask you now to roll over to your right side.
Okay.
And we're going to place the wedge underneath you there.
Oh.
All right. And go ahead and relax.
Okay.
Yeah. And go ahead and lay down.
Okay.
All right. So now we're going to shift it over. Okay, right there. 2 inches below it. Just right there. All right, now we're going to do our external rotation. So we have the patient already rotated onto her right side. We now palpate for the ACEs again, which we're there. And we want it 2 inches below. And we're there. And you have enough light. So now I'm going to check my marker and make sure it's still in place and not obstructing the anatomy of interest, which is there. All right, patient is positioned. We have enough light. Now that we have switched to the external position, we'll get a new measurement. 14. Okay, so now we're going to use an 85 kVp with an 8 mass. All right. So we're going to ask the patient to now don't move and don't breathe. Expose.
All right, guys, now a little review. So for this imaging, we will be needing a 10 by 12 image receptor. We also will be needing a X-ray marker or lead marker to indicate the laterality of what body part is being examined, so the radiologist knows which side they are reading. We will also be needing a 45-degree wedge, which will help us position the patient to make sure that they are not over rotated or under rotated, and also helping the patient or support the patient in that position so it's a little more comfortable for them. We will also be needing calipers, which we will be using to measure the body thickness that we will be needing to penetrate. So we measure from the image receptor all the way on top of the body part, right where the crosshairs are, the central ray enters. So we just kind of want to know how much body part we will be needing to penetrate so we can calculate the technique and the amount of mass that we will be needing for our technique. Lastly, we will be needing a shield. We always want to shield our patients. We want to protect them as much as possible. However, because of the fact that in this case the anatomy of interest was in the gonads, or the area of the gonads, we decided not to shield because that would be obstructing the anatomy of interest. But in general, we always want to shield our patients.
Some clinical indications as to why a doctor can order an X-ray in the Judet method is due to trauma, such as a car accident or someone falling from high elevation on the hips. Another one is to evaluate for acetabular insufficiency secondary to metastatic disease such as cancer, and this is due to bone loss. And also to evaluate for acetabular osteolysis, which can also be caused due to a total hip arthroplasty. And another common reason is for post-op or pre-op. Just to recap, when the patient arrived to the X-ray department, the tech started off with an internal oblique position, which is the left posterior oblique position. This means that the left side is down and the right side is going to be up, and the right side is going to be on the 45-degree wedge. Since we are concerned about the right side, that's why that side is up. You also want to make sure that the hip is centered to the IR. You want the central right perpendicular to the IR and entering 2 inches inferior to the ACEs of the affected side. Then you see the tech measuring the patient's body thickness with the calipers. Some special considerations to keep in mind when positioning patients is to gently palpate in case of fractures, and that patients are going to be in a lot of pain, so just try to gently place the wedge. The purpose of an internal oblique position is to rule out if a patient has a suspected fracture of the iliopubic column, which is the anterior column, and the posterior rim of the acetabulum. Some of the evaluation criteria for an internal oblique position to see if it was done properly is evidence of proper collimation, a presence of a SOD marker placed outside of the anatomy of interest, acetabulum is centered to the IR, the iliopubic column and the posterior rim of the affected acetabulum on the internal oblique is seen, and bony and trabecular detail and surrounding soft tissue is also evident. Then the tech proceeds to do the external oblique position, where now the affected side is down and the unaffected side is up, therefore placing the patient in a right oblique position, where the 45-degree sponge is now on the left side. Now you center the body part to the IR, and centrally should be entering at the pubic symphysis. Some special considerations to keep in mind for this position is that the patient is going to be lying on the affected side, which means they're going to be experiencing a lot of pain, and some patients may or may not be able to rotate to that side. So just something to keep in mind, along with the fact that they are lying on a hard surface.
In addition, if the patient is not able to rest on the affected side, there is also an AP oblique projection modified Judet method, and this is an example of that, and this is also being performed on the right acetabulum on a trauma patient, and the external oblique projection is obtained using a cross table CR and grid IR, and the internal oblique is obtained on a trauma patient in the same position using a vertical CR. As seen. The purpose of an external oblique position is used for a patient with a suspected fracture of the ilioischial column or the posterior column and the anterior rim of the acetabulum. Evaluation criteria for the external oblique position is evidence of proper collimation, presence of a side marker outside of the anatomy of interest, acetabulum is centered to the IR, the ilioischial column and the anterior rim of the acetabulum are seen, and bony trabecular detail and surrounding soft tissues are also evident in the X-ray. Now to discuss the technical factors that were used. First, we used a 10 by 12 image receptor, and the IR was adjusted lengthwise. We used a 40 SID. We used a large focal spot, and for our internal rotation, we used an 85 kVp with 16 mass, whereas on our external rotation, we used 85 kVp with 8 mass. And remember, your mass depends on your measurement from your calipers. Now to discuss some tips and tricks we received from our X-ray techs in regards to the Judet method. They informed us that they usually start with an AP pelvis X-ray to see what they are working with and if the patient can turn or not. Most of the times, patients are not able to turn due to the injury or just being post or pre-op, so you have to work around the patient. They informed us that they actually do most of their Judets portably. Some things to keep in mind when doing Judets portably is that instead of rotating the patient 45 degrees on both obliques, you would be angling your CR at 45 degrees. Therefore, depending on what side you're angling your tube towards, you need to bring your portable IR towards that side as well, so that way it doesn't get clipped with the angle. For example, if you're angling your tube 45 degrees towards the right side, you want to make sure that your portable IR is getting pushed more towards that right side to catch the angle. Another thing to keep in mind when doing Judets portably is to use a grid with your portable IR and make sure that the grid lines are running parallel to the beam. Also note that you will be capturing the full pelvis on both the external and internal obliques versus just the acetabulum, so your collimation line will be larger than 10 by 12 lengthwise. In addition, if the patient does come to the X-ray department, note that you won't be able to angle your tube in a 45 degrees when using the table bucky. Therefore, you will perform them in the gurney if the patient is unable to move.